Welcome to the weekly Neurology Deep Dive. This program is produced by Amer Gavanini.
And in this deep dive, we're focusing on really crucial insights from recent neurological literature.
Insights designed specifically to enhance your clinical practice. Now, please remember, this is strictly for educational purposes.
That's right. No commercial goals here. It's really a summary of the material we looked at.
And we absolutely recommend you read the full paper for a really comprehensive understanding.
Definitely.
Okay, so for those of you who might need the key takeaways right away, here's a quick practical summary.
Good idea.
Health anxiety. It's a distinct, treatable psychological disorder, and you see it commonly in neurology.
Very common.
Yeah.
And it needs positive identification. It's not the same as functional neurological disorders or just, normal health concerns.
Exactly, and this is critical. Reassurance and unnecessary investigations, they're generally ineffective.
And can actually make things worse. They really can.
Right. So neurologists, you play a vital role here in that early, accurate diagnosis and patient education.
Which significantly boosts the chances of a successful referral for psychological therapy.
Especially cognitive behavioral therapy, or CBT.
Which we'll get into. Okay, let's unpack this properly.
Let's do it. We're diving into the nature of health anxiety, something that, as we said, often pops up in neurology clinics.
It really does.
And it's just so vital to distinguish it from, everyday health worries or even from functional neurological disorders.
Yeah, and what's really fascinating, or maybe challenging, is how often health anxiety gets mixed up or conflated with functional neurological disorder, FND.
Right.
The source material we reviewed is very clear. Health anxiety is its own thing, a distinct psychological disorder.
Okay.
It's well understood, it's very treatable, and like you said, common in our clinics. It really shouldn't be called FND.
And vice versa.
Exactly. FND describes those specific motor, seizure, sensory, or cognitive symptoms that really impair functioning. They're separate things, needing different approaches.
That distinction from FND is so important. So could you maybe paint a clearer picture for us? What does health anxiety itself actually look like?
Sure. So at its heart, health anxiety is about excessive worry, persistent worry about being seriously ill or maybe becoming seriously ill.
More than just a fleeting concern.
Much more. And this worry drives people to engage, often obsessively, in what we call safety behaviors.
Like what, for example?
Think about repeated self-checking, self-examining, constantly seeking medical consultations, sometimes, doctor shopping.
Or the endless online searching.
Oh, absolutely.
Yeah.
Endlessly Googling health info, which often just spirals things.
Right.
The DSM-5, the Diagnostic and Statistical Manual, 5th edition, calls it illness anxiety disorder.
Okay.
And the ICD-11, the International Classification of Diseases, 11th revision, used to call it hypochondriasis. Now it classifies it more as a type of obsessive compulsive disorder, OCD.
Interesting classification shift.
It is. And for that diagnosis of illness anxiety disorder, the preoccupation, the worry, it has to be there for at least 6 months.
6 months minimum. Now, here's something really interesting. Why is health anxiety seemingly so common, specifically in neurology?
That's a great question. And it's true, neurologists do seem to encounter higher rates compared to some other specialties.
Why might that be?
Well, there are probably a few factors. One is the significant overlap between common neurological symptoms and the physical or somatic symptoms of anxiety itself.
Like dizziness or numbness?
Exactly. Dizziness, numbness, tremor, fatigue. These can be anxiety or they can be neurological or both. It makes differentiation tricky sometimes.
Makes sense.
Second, neurological conditions themselves can be incredibly anxiety-provoking, right? They often involve potential loss of physical function, cognitive abilities.
Things that really threaten a person's sense of self.
Precisely. It threatens their identity, their independence. Think about getting a diagnosis like MS or Parkinson's that naturally creates anxiety.
Understandably so.
And third, there's also some evidence of potential comorbidity with conditions like autism spectrum disorder and other neurodevelopmental conditions, which themselves are linked to higher rates of anxiety. So it's kind of a perfect storm in some ways.
The source material also brings up this really interesting concept, the reassurance trap. Can you unpack that a bit? It sounds like something clinicians could easily fall into.
Oh, absolutely. And it's such a key insight for us as neurologists. The patient, understandably, comes seeking reassurance. Doctor, tell me I'm okay.
Which seems like the right thing to give them.
You'd think so. But with health anxiety, that reassurance only provides very temporary relief. It's almost like the paper compares it to an addictive drug.
That's a strong comparison.
It is, but it fits. The initial calm wears off incredibly quickly, sometimes within hours or a day or two. And then what happens?
They need another hit of reassurance.
Exactly. It leads to this renewed, often more intense, search for more reassurance. It actually reinforces the underlying fear and the seeking behavior. It's negative reinforcement in action.
So giving reassurance actually strengthens the cycle.
Precisely. It inadvertently validates their belief
Mm-hmm.
that something must be wrong and needs constant checking. Breaking that cycle is just fundamental.
Are there examples of this in the source?
Yes, some really compelling ones, like a patient with chronic migraine and sensory symptoms ended up in the emergency department 7 times.
7 times.
Yeah, got a private MRI scan, saw 3 different private doctors, all driven by this relentless health anxiety cycle.
Wow.
Another case, quite different. A patient with a confirmed diagnosis of Lambert-Eaton myasthenic syndrome, LEMS. A rare condition, yes.
Yes.
But despite the confirmed diagnosis, he developed this severe, quite hidden health anxiety focused specifically on the paraneoplastic version of LEMS.
Even though his wasn't.
Right. And this anxiety profoundly impacted his treatment adherence, his social life. It shows the trap can exist even when there is an underlying organic diagnosis.
That's a really powerful point. It really makes you rethink those interactions. So, okay, if reassurance is counterproductive, what can neurologists do, especially in a busy clinic setting?
It's a challenge, but doable. The overall management usually involves referring to psychological services, right?
Mm.
But the medical consultation itself is often the best place for treatment to actually begin.
How so?
Well, as neurologists, we have this unique authority when it comes to evaluating physical symptoms. Patients tend to trust our assessment of whether something is, quote-unquote, physical.
Right. We're seen as the experts on the brain and nerves.
Exactly. So we're actually well-positioned to explain the presence of anxiety as the driver. But it's absolutely crucial that the patient understands and, importantly, agrees with the health anxiety diagnosis.
That buy-in seems key for the referral to work.
It's everything. Without that agreement, psychological therapy is much less likely to be effective. They won't engage properly if they still think the core problem is purely physical and missed.
Okay, that makes sense. But how do you assess for it effectively in, a standard 15, 20-minute appointment without making the patient feel dismissed?
Yeah, the time pressure is real. But the paper suggests some really good, quite brief questions you can weave in.
Like what?
Simple things like, do you find yourself worrying a lot about your health? What's the absolute worst thing you fear could happen? When did you notice you started worrying more intensely about your health?
Getting at the nature and timing of the worry.
Precisely. And also asking about the impact. How has this worry affected your work, your social life, your family?
And maybe questions that tap into those behaviors.
Yes, exactly. Follow-ups that often resonate are things like, have you found yourself spending a lot of time online researching symptoms?
That's a common one.
Very. Or, do you find that doctors reassure you, but maybe just for a day or two, and then the anxiety comes flooding back? That one often gets a nod of recognition.
Those sound like really useful, non-judgmental questions. Now, this brings up the big one, investigations. Scans, tests. Patients often expect them, sometimes demand them. How do we handle that?
Yeah, the million-dollar question in neurology clinics, sometimes right. Look, we should absolutely arrange and complete tests that are clinically necessary, based on history, based on exam.
But not just for reassurance.
That's the key distinction. Ordering tests just to provide reassurance often subtly implies that you, the doctor, still have some diagnostic doubt.
I see.
And for the patient with health anxiety, that test then becomes just another thing to obsessively check or worry about. A scan might be negative today.
But what about next month? Or what if they miss something small?
Exactly. It fuels the what-if cycle. For someone with normal health concerns, a negative test can be genuinely reassuring. But for pathological health anxiety, it often makes the core problem worse long-term.
That's a critical difference.
And another practical point, if investigations are needed, it's really important to get them done and dusted before psychological treatment starts. Outstanding tests hanging over them can really undermine therapy.
Okay, good point. So let's say we've done the necessary workup, we're confident in the health anxiety diagnosis. How do we actually explain this to the patient without them feeling brushed off or told, it's all in your head?
That is probably the most delicate part of the whole process. It requires real skill and empathy.
What does the source suggest?
It emphasizes ruling in health anxiety, not just ruling out everything else. Frame it positively. Explain that health anxiety is a real condition. It's common, it's often misunderstood, but crucially, it's treatable.
So validate it as a diagnosis in itself.
Absolutely. You can even briefly mention the diagnostic criteria or share anonymized, relatable examples. This helps them see it as a legitimate medical issue, not a dismissal.
What about the internet searching aspect?
Acknowledging that can be very powerful. Talk about query escalation, how searching for, say, tingling fingers can quickly lead algorithms to suggest really scary, rare diseases.
Many patients will have experienced that firsthand.
They will. And validating that experience helps build rapport. It's also super helpful to explicitly explain the known physical symptoms of anxiety.
Because many patients don't connect physical feelings with anxiety.
Exactly. They often equate anxiety only with worry or panic attacks, explaining that anxiety can cause dizziness, fatigue, muscle tension, even fasciculations.
Benign fasciculations are mentioned specifically, right?
Yes, very common, seen in up to half the population in one study, apparently, and often accompany health anxiety. Making those links explicit can be eye-opening for patients.
So the mantra is provide explanation, not just reassurance.
That's it perfectly. Provide the framework for understanding. And finally, offering a follow-up appointment can make a huge difference.
Why is that important?
It shows you're taking them seriously, that you're not just diagnosing and ditching them. It gives them time to process, ask more questions, and it allows you to check their understanding and reinforce the plan.
Okay, that makes a lot of sense. So let's move forward. The patient accepts the diagnosis, understands the plan, and they're referred for psychological therapy. What does that treatment typically involve?
So the most effective treatment we have for health anxiety is psychological therapy. And within that, cognitive behavioral therapy, or CBT, really has the strongest evidence.
CBT, what's the general approach there?
Broadly speaking, CBT helps patients understand how their anxiety is being kept alive, essentially, by certain patterns of thinking, cognitive distortions.
Like catastrophizing minor symptoms.
Exactly. Overestimating the likelihood of having a serious illness based on ambiguous feelings. CBT helps them identify and challenge these distorted thoughts.
And presumably address the safety behaviors too.
Yes, that's the other key part.
Mm-hmm.
Gradually reducing the reliance on those checking behaviors, the reassurance seeking, the avoidance,
Yeah.
breaking that cycle we talked about.
How effective is CBT, really? Do we have solid data to share with our listeners?
We absolutely do. The evidence is actually quite impressive. There was a meta-analysis of 14 randomized controlled trials.
Okay.
Involved over 1,500 people, 1,544 to be exact. It found large clinical effects, a change of about 1 standard deviation in symptom scores.
That's a substantial improvement in statistical terms.
Very substantial. And then there's the CHAMP trial, another big study, 444 patients. They found a sustained difference in health anxiety scores even 8 years after the initial CBT.
8 years later. Wow, that speaks to long-term benefit.
It really does. It highlights that this relatively brief psychological treatment can have lasting effects. And, not unimportantly, it's also highly cost-effective.
How so?
By reducing all those repeat consultations, emergency visits, unnecessary tests, it saves the healthcare system money while improving the patient's quality of life. It's a win-win.
That's compelling. Now, is CBT the only option, or are there other therapies?
CBT definitely has the most robust evidence base specifically for health anxiety. But other approaches can be helpful too.
Such as?
Acceptance and commitment therapy, or ACT, is one. And there's growing interest in internet-delivered treatments, which can improve accessibility for some.
What about medication?
Medication can have a role for some patients. Things like SSRIs, the selective serotonin reuptake inhibitors, or clomipramine meds often used for anxiety or OCD.
But are they specifically proven for health anxiety disorder?
That's the important caveat. There aren't specific large-scale randomized controlled trials for medication targeting health anxiety disorder directly, the way there are for CBT.
So more general anti-anxiety or anti-OCD effects.
Pretty much. And another thing to be really mindful of with medication in these patients is the nocebo effect.
Meaning they might experience side effects just because they expect to?
Yes, their anxiety and hypervigilance about bodily sensations can make them more prone to perceiving or attributing negative effects to the medication. It's crucial to discuss this possibility openly with them.
Good point. This has all been incredibly informative about diagnosis and treatment. But what about the bigger picture, the long-term prognosis? This condition sounds like it can be quite devastating.
It absolutely can be, and this is where some recent data is quite sobering, actually. It really underscores why taking this seriously is so important.
What did the data show?
Recent population registry data from Sweden. It showed an increased risk of all-cause death among patients diagnosed with health anxiety. The odds ratio was 1.6 compared to the general population.
An increased mortality risk.
Yes, and perhaps even more concerning, the risk of suicide was significantly higher. The odds ratio there was 4.0.
4 times the risk. That's stark.
It is stark. It really highlights the severe, potentially life-threatening implications if health anxiety goes unrecognized and untreated.
But the key message is treatability, right?
Absolutely. That's the crucial counterpoint. While the risks of untreated illness are serious, health anxiety is highly treatable with the right approach, like CBT. So identifying it early is paramount.
Okay, let's bring it back home then. Time to reiterate that practical summary for everyone listening.
Good idea.
So number 1, health anxiety is a distinct psychological disorder, treatable, common in neurology.
And it needs that positive identification. It's separate from FND, separate from normal worries.
Critically, avoid the reassurance trap. Unnecessary investigations often make it worse. They don't help.
Explanation over reassurance. That's key.
And neurologists, you are really on the front line here. Your role in early, accurate diagnosis, in educating the patient, it's vital.
And doing that well significantly improves the chances of them engaging successfully with psychological therapy, particularly CBT.
That really sums it up.
You know, if we think about the bigger picture here, health anxiety, it's really just like, say, a B12 deficiency or a thyroid disorder that we routinely screen for and treat.
What do you mean?
It's a highly treatable condition that significantly impacts neurological patients, and it's one we simply cannot afford to miss in our daily practice. It should be on our radar.
That's a really powerful thought to end on, a call to action, really, for all of us in the field. This deep dive has pulled these key insights from the paper Health Anxiety in Neurological Settings by Green and Stone.
And we really do encourage you to read the full paper. It explores this critical topic in much more detail.
Absolutely. Thank you so much for joining us on this weekly neurology deep dive.